Sir, how do you perform IVF or test tube baby treatment at your center? How many times patient has to visit, and why do you say that your center success rate is comparatively better?
See, there are multiple things you asked. One is how do I perform IVF and how do you perform a test tube baby treatment to a patient, and how many visits they require, and why our success rate is relatively better. These are three very important questions. A patient comes to me, a couple comes to me, and they ask me. My simple answer is I never do IVF in batches. I never take many patients in a day, maximum 4 or 5, because I cannot do justice with the patients, because my limitation is I'm having my embryologist Dr. Rinku Banerjee with me. I'm a gynecologist. We have this embryology lab, so we can handle 4 or 5 patients in a day. Number two, every patient is having a different reason of infertility, and every patient, every couple is having a different type of treatment also. So you cannot generalize the treatment with every patient. Every patient needs a different treatment protocol. Number three, which patient is producing more eggs and requires frozen embryo transfer cycle later on, which patient requires ICSI, which patient requires testicular sperm extraction. This has to be decided when there is a first visit. Now, what is the first visit? It is not required that first visit should be on 21st day, on that day and that day. Anytime they can come for consultation. And first thing, when they come to me, I see three things. To have a good crop, like baby is a crop. So have a good crop, you require a good seed and a good soil. Here the seeds are female's egg and husband's sperm. And the soil is the lady's uterus, endometrium. My prime focus is on quality of the seed and quality of the soil, that is endometrium. The first visit I do all these things. Most of the time I do a pre-IVF, pre-test tube baby hysteroscopy. Why? Because hysteroscopy gives them better idea of the endometrium, the soil, and if I do a simple slight damage to that soil, it creates more success rate. It is now quite established and I follow that. Now patient comes to me for actual IVF on second day of the cycle. She will be in periods and day 1 will be counted as 1, and she will be in my clinic on day 2. On day 2 I do another transvaginal sonography to see whether she is fit for that cycle or not, should we start it or not. Most of the time it goes for 10 days or 11 days injection. It is not required that she should be with me for 10 days. No admission, hospital admission, no bed rest, no operation. She doesn't require any hospital admission. So she can have second day injection and she can take next injections for 7 days and come to me for 7 days. On 7th day I do a sonography and see the monitoring and do the monitoring whether eggs are growing or not. And most of the time I then call her on day of egg retrieval. That means if you see for IVF cycle only 3 or 4 visits are enough. Most important thing is on the day of egg retrieval, if I do a ICSI, like we do ICSI under this microscope, and or we do a conventional IVF, or we do testicular sperm extraction. When we do the fertilization, mostly now 100% we are doing day 5 blastocyst transfer. Why? Because what happens, most of the centers they are doing day 2, day 3 transfer. But what happens in day 2, day 3, all the embryos look same. But which embryo is going to grow and gives to produce a baby, it is very, very difficult on second or third day. What we do in our center routinely, we allow this embryo to grow in this type of incubator. These are incubators. If you open this, then these incubators, they are having these dishes. These dishes, they have embryos inside in a minute droplet. We keep it with temperature, with carbon dioxide, with a particular amount of oxygen, so that the environment should be good, like an uterine tube. because it happens in fallopian tube. We grow that second day to third day till day 5, because uterus also allows day 5 transfer. So we do a selection on day 2, day 3. So only those embryos which wins the race will reach on day 5 or day 6. Even there is a shell around the embryo, we try to help them in a spontaneous way to hatch. So that the best embryos are selected on day 5 or day 6. They might be lesser than day 2, day 3, but they will be better, best amongst the lot. So if you transfer a best embryo into uterus, definitely the chances of implantation will be more. That is the reason wherever in the world the blastocyst transfer is being done, the success rate hovers around 60-65% for embryo transfer. So the blastocyst transfer why we are doing, that's why our success rate is relatively better than day 2, day 3 transfer. This is the crux of the matter, and wherever this procedure is being followed, the success rate is usually more. But there is a problem also in blastocyst transfer, that it might be possible that on day 5 or day 6 there might not be any blastocyst, nobody wins. So what happens? Then there should be a clear understanding between my patient and me, and I bluntly, clearly, truthfully tell them that I don't have any good embryo on day 5 or day 6, hence I am cancelling the embryo transfer. So there should be a clarity amongst the patient and the doctor. If this happens, definitely that center will be doing better, having a better success rate. This is the reason why we are having 100% blastocyst. We try to do that 100% blastocyst and with a better success rate.